Dear Chair, dear audience, it's a pleasure to present the progress of my PhD topic, the title of which is Investigating the Efficiency of Arterial and Venous Endovascular Procedures. My name is Dávid Laczkó. I'm a medical doctor and a PhD student at the Department of Interventional Radiology at Semmelweis University. My vision is to eliminate the consequences of peripheral artery diseases by making endovascular procedures more available and widespread, and my mission is to provide clinicians with up-to-date knowledge to help them choose the most suitable procedures. In order to achieve this, I have two ongoing projects right now. The title of the first one is Investigating the Effectiveness and Safety of Embolic Agents Used in Bronchial Artery Embolization. What we know is that severe and recurrent hemoptysis can be a life-threatening emergency with a mortality rate of around 70 to 80%. Now, we also know that 90% of these cases are caused by the bronchial circulation, either due to lung cancer or inflammation. Possible treatments include conservative treatment, which is effective in short term, but the long-term effectiveness is unproven. Surgical removal of a part of the lung, which has a very high perioperative mortality, and the gold standard, the endovascular treatment. Now, there are three main types of embolic agents that can be used in the endovascular treatment. Particle agents, namely PVA and microspheres, liquid agent, which is also known as N-butyl cyanurate, and coils can be also used. However, these are not first-line treatment because it often prevents the further procedures if the hemoptysis returns. So our clinical question is, are different embolic agents effective and safe in bronchial artery embolization for hemoptysis? We've investigated patients presenting with hemoptysis, either treated with particle embolic agents, PVA and microsphere, or liquid agent, N-butyl cyanurate. Our primary outcome was 1-year hemoptysis-free survival, and secondary outcomes included technical and clinical success, perioperative and 1-year mortality, and complication rates. Our hypothesis is that particle and liquid embolic agents are effective and safe in the treatment of hemoptysis. Here you can see my search key, and we've conducted a systematic search in the following databases. We found over 5,500 articles, and in the end, we managed to extract data from 66 articles. Here I would like to present my first outcome, which is clinical success. What we mean by clinical success is that after a technically successful procedure, the hemoptysis completely or substantially stops during the first 24 hours. This is a very important outcome because it represents the short-term effectiveness of the embolic agents. Here, you can see only half of the first forest plot dealing with the results of the liquid group. Now, all of these studies were retrospective observational cohort studies, and the results are in proportions ranging from 0 to 1. 0 meaning that none of the patients had a clinically successful procedure, and 1 meaning that all of the patients had a clinically successful procedure. Here you can see that the pooled effect size in the liquid group was 0.95, meaning that on average, 95 patients out of 100 patients had a clinically successful procedure. Here you can see the other part of the forest plot. Here you can see the particle agents investigated in the publications. Again, all of these were retrospective observational studies, and the pooled effect size was as well 0.95, meaning that in regard of the clinical success, neither statistical and clinical significance could be found. Also, I would like to point out that in the particle group, we found 4 outliers. Reason for these being outliers is that these articles only involve patients diagnosed with lung cancer. The next outcome I would like to present is the 12-month recurrence rate. Again, all of these studies were retrospective observational studies, and the outcomes are in proportions ranging from 0 to 1. However, this time 0 meaning that none of the patients experienced recurrence, 1 meaning that all of the patients experienced recurrence. This is also an important outcome because it represents the long-term effectiveness of the different embolic agents. The pooled effect size in the liquid group was 0.14, meaning that 14 patients out of 100 patients on average experienced recurrence. Again, we have an outlier in this group as well. In this study, also only lung cancer patients were investigated. Here you can see the other part of the forest plot, investigating patients treated with particle agents. The pooled effect size was 0.17, and again, we have outliers. Again, these articles only investigated patients with lung cancer. And we could say that neither clinical nor statistical difference could be observed between these two groups. So based on these outliers, we've decided to do a subgroup analysis between the malignant and non-malignant patients. And you could see that the clinical success in the malignant group was 0.74, and the clinical success was in the non-malignant group was 0.97, which is clinically and a statistically significant difference. We've also investigated the 12-month recurrence between these two subgroups. Again, in the malignant group, the pooled effect size was 0.66. In the non-malignant group, it was 0.11, which is a very clinically and statistically significant difference again. To better visualize these results, here you can see the different recurrence rates at different times between these two groups. And as you can see, it can be visualized that a very big difference can be seen between the two etiologies of the hemoptysis. So we have a few strengths and limitations in our study. Strengths include that a large number of studies were included, and we have a definitive answer to our research question. Limitations is that only retrospective observational studies were included, and the populations were quite heterogeneous. In conclusion, we can say that particle and liquid embolic agents are both effective and safe in the treatment of hemoptysis with the bronchial artery embolization. Implication for practice is that there seems to be no risk associated with using either agent for embolization, and the implication for research is that investigators should be free to study all these agents in the randomized controlled trial. Here you can see the progress of my first project. We finished with the manuscript, and we are sending it to internal review in the next few days. A few words about my second project, where we are comparing the effectiveness and safety of surgical and endovascular treatment of symptomatic carotid stenosis. We know that stroke is the second most common cardiovascular disease, annually causing over 1 million deaths in Europe alone. Now, 20% of these strokes are caused by the stenosis of the internal carotid artery. Possible treatments include base medical therapy combined with either the surgical removal of the stenosis or the endovascular removal and dilation of the stenotic part of the internal carotid artery. In the endovascular treatment, a so-called device, embolic protection devices, can be used. However, in the most recent guidelines, the usage of this device is very controversial, and no recommendations were given whether to use it or not. So a clinical question is carotid stenting with an embolic filter as effective and safe as carotid endarterectomy in the treatment of symptomatic carotid stenosis? We would like to involve patients presenting with symptomatic carotid stenosis, either treated with carotid stenting using an embolic filter or undergoing carotid endarterectomy. Our primary outcome will be 30-day stroke rate. Secondary outcomes will be perioperative stroke rate, perioperative and 30-day mortality and complication rates. Our hypothesis is that both stenting with an embolic filter is as effective and as carotid endarterectomy. And our clinical implication is that we could reduce the perioperative stroke rate with the appropriate procedure. We've had an interdisciplinary meeting where we started to draft the protocol. Here you can see a preliminary inclusion and exclusion criteria. Mainly, we want to involve adult patients presenting with hemispherical symptoms with a known and confirmed stenosis, and we will exclude patients that are presenting with symptoms more than 180 days since the beginning. To summarize everything, we have these two projects going at the moment, and we are planning to submit the first one in September, October. And I would like to end my presentation with one of my favorite quotes by W.C. Fields: "If at first you don't succeed, try again." Thank you for your attention.
Hello, just one question, please. Are the results of your analysis dependent on the underlying cause of hemoptysis? I mean, I noticed you mentioned you excluded the patients with lung cancer, but did you exclude other kinds of populations, for example, patients with Randu-Weber syndrome?
Sorry? What?
Patients with Randu-Weber syndrome.
Mm-hmm. So we've made two subgroups where we've divided the patients between the malignant group and the non-malignant group. Now, in the non-malignant group, everything that is not cancer or metastasis are included. Any vascular diseases, pneumonia, bronchiectasis, everything other than lung cancer. So, and as you could see in our results, it was quite dependent, the success and the long-term success, based on the etiology of the hemoptysis.
Thank you, I understand.
Thank you.
I also want to ask you that could you please discuss a little bit more about this etiology, because there was a big difference between the two groups regarding your first project,
yeah.
And what could be the background, the reason for that?
So the main reason is what people theorize in the literature is that lung cancer is a very destructive process. It can erode into the bronchis, it evades the walls of the arteries, so it can cause much more bleeding and much more frequent bleeding. And mainly the other etiologies are more of like a slowly forward process. So it doesn't really cause that big of a symptoms in a short amount of time. And also both the inflammations and the lung cancer can cause the neovascularization of the lung. And these newly formed vessels have very thin walls. And these walls are much more prone to breaking, which also contributes to the fact that they usually cause hemoptysis.
Okay, thank you.
Thank you.
Nice presentation. I like both parts. They are quite different, but for the first one, why shouldn't you be quite pragmatic and your endpoint of interest could also be in-hospital death? Because that is what matters for the patients. Just to go for malignant in-hospital death. If you can prevent in-hospital death, then you did something for the patients, because they have very short survival rates if they are starting with hemoptysis. That would be my pragmatic thinking for the first one. Maybe you could comment on that. And I would focus more on malignant group, because for them it really matters to prolong life. Yeah. For the second one, so please be careful when planning the project, because you need to consider the guidelines. They're very specific. If you have this and that proportion of stenosis, then it's endovascular. If you have a different one, it's surgical. And now for the question, this embolic filter, where is it positioned in the stent? Because if you put the stent on the arteriomatosis plaque, then if it's in the middle or in the proximal part, then it prevents cardioembolic events. If it is in the distal part, then it can prevent embolic events from the plaque. So what is your comment on that?
So these filters are placed after the stenosis. And basically, why people say that they don't like to use this is that you still have to put this filter through the stenosis. And during this, it's possible to cause a stroke. Yeah. However, other people, based on experience, when they remove the filter, they can see that it is full of the emboli. So they think that there's no way that they will do a procedure based on the experience. So yeah, these filters are placed after the stenosis. And for the first question, we've investigated mortality. It will be in the systematic review part. We couldn't analyze this data. And what is another implication is that we want to analyze the malignant group. We want to do a subgroup where patients were divided between liquid agent and particle agents to maybe see if one of the agents were more useful in this subgroup. However, we didn't have enough data for that as well. But